Uh, Thank you very much for the very nice invitation, nice introduction. I have many friends in the room, and apologies for yesterday dinner. I took a 20-minute nap, and I woke up at 2 in the morning, so I'm jet lagged. So I'm delighted to give you a brief history of immunity in PAH. And to be frank, there will be a lot of overlap, obviously, with the other speakers. So I will try to make it quite progressive, focused on my main interest, and I will start with my disclosures. I don't know why it doubles like that. There is an anaphylaxis? No? So you will not know my disclosures. Okay, I think it's a good start. Okay, this is my plan today, and the brief introduction will repeat some of Christina's point, and Christina has made it very nicely that pulmonary arterial hypertension is a subgroup of pulmonary hypertension. It's called group 1 pulmonary hypertension, and it's defined by chronic elevations in mean pulmonary artery pressure, and we know for sure that the reason why the pressure is chronically elevated, it's because there is a major remodeling of the small pulmonary arteries. So the major point in pulmonary arterial hypertension is remodeling, but it's certainly the end of a very long ongoing process, and we have to understand what started, who came first, what happened, what was the starting element, and how did it progress to that. You need to occlude about 70% of your vessel to start being pulmonary hypertensive at rest, and you need to occlude at least 50% to have some symptoms at exercise. So it's a very difficult disease to diagnose early unless you know a patient as a risk factor, like scleroderma patients, like patients with a BMPR2 mutation, etc. So the last thing is that this condition obstructs the small pulmonary arteries, and it will act on the right side of the heart. And the patients are symptomatic because of right heart failure. And today we will not discuss inflammation in the right heart, etc., but certainly there is something to investigate in that field. So it's a rare disease, pulmonary arterial hypertension. The prevalence in France is between 15 and 25 per million, same in the US. The pathophysiology has really emphasized the importance of the pulmonary artery endothelial cells, and there is a large amount of different mediators which are produced by the dysfunctional pulmonary artery endothelial cells, which have been extremely important for vasoconstriction and for vasodilation, and this has led to the development of a lot of treatments. We are very lucky in a rare disease to have 10 drugs approved worldwide. It's unbelievable. And these 10 agents all focus on a dysfunctional pathway of the endothelial cells. And we should never forget, and I know you are very strong in Stanford on that, we should never forget that this disease is dramatic, that this disease is not curable in most cases, and that many patients, despite the beautiful drugs we have, will end up one day with a lung transplantation, and refractory patients should be really considered for lung transplantation. So Christina has showed this picture. It was in 2004, 10 years again, same review article, more or less same authors, okay, it's not duplication, but not far. And you see that the pathways are still 3, and we have refined a little bit how to interfere with endothelin receptors, with the NO pathway, with the prostacyclin pathway, but we still keep on working on the 3 pathways. And we really have to think outside the box, because this is a survival rate of our patients in France. It's the same everywhere in the world. And if you make real incident cohorts of patients with PAH, you will never find less than 7% yearly fatality rate in PAH. So PAH is a dramatic disease. We can improve very much the outcomes of our patients, but most of them are not doing as well as we wish, and we have to develop new strategies. So the new strategy is early detection for sure, goal-oriented therapy with very ambitious goals for sure, initial combination therapy of what we have for sure, and developments of novel therapies. So some people try to develop one more new agent targeting the 3 pathways, but we really think, and that's the reason why we are here today, that we have to target other things, as Marc said, as add-on therapies. In asthma, you have the bronchodilators, the inhaled corticosteroids, but when patients are refractory, you add something. Same here, we don't want to replace what's working okay. We want to develop add-on therapies, and there is a long list of targets, and today we will really focus on inflammation and disimmunity. So inflammation and disimmunity, you could speak for a very long time, and we have a whole day discussion, so I will just focus on three important points. First, histology and circulating cytokines with a focus on interleukin-6. I was happy that Marc said that it was an important one because I share the same view. Then autoimmunity, and then endothelial cell contribution to inflammation and remodeling. It's not because the cell is not a very common immune cell that it's not very active in the immune reaction, and endothelial cell in pulmonary hypertension is paramount. So if you make cartoons on pulmonary artery remodeling, you always include some flavor of inflammatory cells in blue here. So sometimes it's a loose infiltrate, sometimes it's a very structured infiltrate, sometimes organized in tertiary lymphoid organs, quite interesting, and I will spend some time. But I don't know many pathologists who contest the fact that inflammation is present in pulmonary vascular lesions. Many pathologists doubt that it's very important because they see sometimes very small inflammatory infiltrate, but they all agree that inflammation is present. And the paper by Savai, which has been presented by Marc before, clearly shows that most of the inflammatory players are overrepresented around or inside the remodeled pulmonary arteries in PH. Increased numbers of macrophages. Rubin presented that in 1994, and now everybody can confirm it's true. Monocytes, dendritic cells, T cells, cytotoxic T cells, helper T cells, and B cells. The only cell which was down-regulated in this pathology descriptive study was the FOXP3 Tregs. So interestingly, the only one which was down was the regulatory T cells, and it echoes what Marc said before. So cytokines, you mentioned that there are too many to be so excited about it, but some are really important. And if you do a rapid literature screen on cytokines and pulmonary hypertension, one of them is coming quite a lot, it's interleukin-6. But many others are also overexpressed in the lesions of pulmonary hypertensive patients or in the bloodstream of pulmonary hypertensive patients. But at the end of the day, interleukin-6 is one of the most important ones. This is a paper published 5 years ago by the Cambridge group, Elaine Soon and colleagues, showing that the blood circulating cytokine levels are associated with poor outcomes when the cytokine level is high. And interleukin-6 was clearly one of the most important cytokines in terms of predicting long-term outcomes. And with Jean-Luc Krakowski and the French network of pulmonary hypertension, we have made a cohort of incident patients with idiopathic PH, and we have measured a long list of cytokines. And you will see here that several are independently associated with long-term outcomes, outcomes being defined as survival, so no doubt about the importance of this outcome. And you see that once again, interleukin-1, interleukin-6, 13, and TNF were important cytokines associated with long-term outcomes. 20 years ago, in my clinic, we were measuring cytokines, and interleukin-6 and interleukin-1 were quite elevated in most patients. And then in animal models of pulmonary hypertension, for example, monocrotaline-induced pulmonary hypertension, when pulmonary hypertension is developing, interleukin-6 was increasing in the bloodstream. And interestingly, two animal models, interleukin-6 overexpression induces pulmonary hypertension, either in normoxia, but most importantly in hypoxia. And the other way around, interleukin-6 knockout mice are less prone to develop hypoxic pulmonary hypertension. So very recently, we had a Japanese postdoc in the department who had the possibility to work in close collaboration with Christophe Guignabert. And the main topic of his study is interleukin-6 and interleukin-6 receptor upregulation in pulmonary artery smooth muscle cell in order to see whether the beautiful drugs currently developed in rheumatology and in internal medicine could be one day proposed to our patients, as you did too with rituximab. So to start with, in pulmonary hypertension, and this is not published yet, you have an increased expression of interleukin-6 receptor in the pulmonary artery smooth muscle cell. You see here SM22, and it overlaps and it becomes yellow. So the pulmonary artery smooth muscle cell express a lot of interleukin-6 receptor as well as GP130. And interestingly, interleukin-6 induces p-STAT, so phosphorylation of STAT3 via an interleukin-6 receptor pathway. And you see here interleukin-6, so baseline, then 15 minutes, 30 minutes after interleukin-6 exposure, and phosphorylation of STAT3, which comes very quickly in IPH smooth muscle cells, whether it does not unlike control cells. So interestingly, interleukin-6 circulates in the bloodstream of our patients. Interleukin-6 receptor is expressed on pulmonary artery smooth muscle cell, and differently from controls, when you add interleukin-6 on smooth muscle cell cultures, STAT3 is phosphorylated. So it triggers something. And we have also studied whether interleukin-6 receptor antagonist was blocking interleukin-6 induced phosphorylation of STAT3. And as you can see, when you add the interleukin-6 receptor antagonist, you downregulate, of course, the phosphorylation of STAT3. And most recently, we have showed that interleukin-6 receptor blockade with a monoclonal antibody reverses pulmonary hypertension in the Sugen chronic hypoxia rat model of severe pulmonary hypertension, established pulmonary hypertension. You see here the decrease in pulmonary vascular resistance, increase in cardiac output, and improvement in right ventricular hypertrophy. So altogether, this was a flavor of cells and cytokines with a focus on interleukin-6. We strongly believe that some of these players are important in pulmonary hypertension, not only in animal models, but also in human disease. One of the strengths of my group is to have access to the French program of pulmonary hypertension transplantation, and we have lots of tissue available with cell culture, etc. Then I would like to focus more on autoimmunity. So Christina has showed the classification of pulmonary hypertension, and you know that we are dealing today on group 1 PAH, and of course, when you take 100 patients with group 1 PAH, 1/4 will be associated with connective tissue disease, 3/4 of them scleroderma. So connective tissue disease is not one line among others. It's a prominent cause of group 1 PAH. And in my clinic, for example, half of the patients have idiopathic, heritable, or drug-induced, and 20% have connective tissue disease associated PAH. In addition, you have inflammatory conditions like HIV, infectious conditions like HIV or portal hypertension or schistosomiasis who are associated with PAH. There is a very strong flavor of inflammation and immunity in PAH. Something really important, and we work a lot with my colleagues at the Paris University, Luc Mouton, for example, in Cochin Hospital. Quite importantly, patients with idiopathic PAH, they are different from controls. They are characterized by a large amount of autoantibodies circulating in their bloodstreams. Even though they have no arthritis, no skin disease, sometimes they have Raynaud's phenomenon, etc., but they don't look like a connective tissue disease. They are characterized by a multitude of autoantibodies directed to nuclear antigens, endothelial cells, smooth muscle cells, and fibroblasts. And quite interestingly, if you compare the red square and the blue square, you see that the number of autoantibodies in the scleroderma patients and in the idiopathic PAH patients are broadly the same. So the circulating blood of these patients is full of autoantibodies, and we know that these autoantibodies can trigger apoptosis of the endothelial cells. They can provoke smooth muscle cell contraction, and they can, for example, in this study, you see here scleroderma, here idiopathic PAH, quite a large number of autoantibodies detected, and these autoantibodies can bind to smooth muscle cell and induce cell contraction. And the paper by Norbert and Marc in the ERJ showing that a multiple step series of or chain reaction may explain why an initial endothelial cell injury could induce in the context of immune dysregulation an impaired injury resolution and remodeling. So regulatory T cells. Marc has mentioned it. There will be a talk on that, but we know that Tregs are altered in autoimmune disease. When you have an autoimmune disease, there is less Treg activity, and we know that Treg activity can be regulated by different mediators, including adipokines such as leptin. And leptin is a very complex. Okay, I cannot see it here. So should I say something?
Look at the screen.
The screen is.
No, look at the projected.
Ah, okay, yeah, you're right. So. Okay. Okay. So leptin is quite complex. It has central effects, food intake, of course, and it has peripheral effects, including strong action on T cell function. And in immune response, leptin is really important in innate and adaptive immunity. And the hypothesis we wanted to test with my colleagues in Paris was that in pulmonary hypertension, in group 1 PAH, we could have an elevated leptin circumstance which could favor low-grade inflammation and degenerative disease, and this could be a hallmark of autoimmune disease, for example, multiple sclerosis, etc. So this is the hypothesis here: high leptin, down-regulation of Treg, disimmunity, and idiopathic PH. Of course, it's difficult to demonstrate in human. The only thing we can do is measure and see what's happening. So the first thing, very simple, leptin circulating levels in controls. In idiopathic PH and in scleroderma-associated PH, you have increased amount of leptin in PH, irrespective of the cause. The Treg numbers as percent of CD4 positive cells is not altered, but you have an increased amount of Tregs bearing the leptin receptor. And interestingly, when you add leptin to Tregs expressing the leptin receptor, you down-regulate STAT3 phosphorylation, indicating that the functional status of Tregs is down. And you see here, this is in bloodstream of patients with PH. These are controls and these are PH. We could confirm that in PH, patients have a down-regulation of the circulating Tregs, characterized by a decreased STAT3 phosphorylation. So interestingly also, it doesn't project very well, but in PH, a major source of leptin was endothelial cells, and you see here in cell culture of pulmonary arterial endothelial cells, you have more pronounced leptin production versus controls. So this is a cartoon explaining what we feel is important. Adipocytes are important source of leptin, but also pulmonary endothelial cells in pulmonary hypertension. There is an increased leptin production, increased leptin receptor expression on Tregs. This will lead to decreased phosphorylation of STAT3, meaning inhibition of Tregs, promoting inflammation and autoimmunity. After this paper, we have published a second one last year, and a third one is coming, expanding the Treg abnormalities in other group 1 PH, including heritable and other connective tissue disease-associated PH. So if you deal with Tregs, as Marc said, you always have to see the other side of the regulation. It's Th17, which is more promoting inflammation and autoimmunity. And interleukin-6 is clearly a key regulator of Treg Th17 balance. With Aurélie Hautefort in the department, we have showed recently that the freshly isolated CD4 positive T cells activated with PMA and ionomycin have increased production of interleukin 17. And quite interestingly also, circulating cells are characterized by demethylation of IL-17A, indicating that in PAH you have an increased Th17 activation. So decreased Treg, increased Th17. This paper, maybe you have seen it. It's quite a fascinating paper published in the Proceedings earlier this year. It's an animal study, of course. And in hypoxia, what these Japanese authors have showed is that pulmonary endothelial cells and pulmonary artery smooth muscle cell will produce interleukin 6, which will promote the Th17 increase, and these Th17 cells will favor macrophage activation and pulmonary artery smooth muscle cell proliferation. So the Th17 story is certainly very appealing in PH. So now a word about autoimmunity around the vessel, local autoimmunity. These are sections from patients transplanted in Paris for pulmonary arterial hypertension. And you see here, these are dendritic cells infiltrating the adventitia of these patients. And this is a tertiary lymphoid organ, so an organized lymphoid tissue. And as you can see here, in animals, Kurt Stenmark's group could show the same phenotype, the same abnormal lymphoid tissue. But in humans, it's sometimes quite impressive. And this is a number of tertiary lymphoid tissue in controls and in IPH in a pathology study published by Frédéric Perrault. So what is certainly important is that this pulmonary lymphoid neogenesis could be the source of cytokine and chemokine production, at least locally, but also the source of immune response, including autoimmune response. And what we are doing right now, and unfortunately I cannot show you data yet, we have a large tissue bank, as I said. We can identify the tertiary lymphoid tissue. We can also extract the lung lymph nodes at the time of lung transplantation, and we can also take blood from the patients. And what we try to identify is whether these immune sources are characterized by polyclonal diffuse inflammatory responses or oligoclonal targeted immune response, possibly autoimmune. So what we do right now, and the study is completed, we microdissect the tertiary lymphoid tissue, and we can then evaluate the diversity of the T and B cell response. So these tertiary lymphoid organs may be linked to autoantibody production and explain, at least in part, what's going on in our patients in the setting of abnormal Tregs, recruitment of dendritic T cells, and a whole series of abnormal cell responses, which will be discussed later. To conclude in 2 minutes, endothelial cell contribution to inflammation and remodeling. It's not because we are fascinated by inflammation that we should ignore what is really prominent in PH, endothelial cell dysfunction. And with Frédéric Perrault, we have recently published in the Blue Journal a couple of months ago a paper showing that pulmonary endothelial cells derived from IPH patients exhibit a pro-inflammatory phenotype. So very simply, you take the cells from the lungs of patients at the time of lung transplantation, you have controls on IPH, and you compare the cytokine production of these pulmonary artery endothelial cells, and you see that IL-1, IL-6, IL-8, IL-12, MCP-1, all these cytokines are increased, but also adhesion molecules. So first, these patients are characterized by activated endothelial cells prone to produce cytokines and express adhesion molecule. Then if you study the sections of patients with PH as compared to control, this is the vessel lumen, not much ICAM, VCAM, E-selectin expression in normal lung tissue, while there is marked expression in PH. Then we take the cells, we grow them, and we put on them a flow of freshly isolated PBMC, and at 3 hours, we measure the adherent cells. And you see that if you compare controls with PAH, the endothelial cells from control are more able to stick to block circulating PBMC. And then they showed that a major cytokine called MIF, which is produced in the lung mostly by lymphocytes, is overexpressed in PAH, and that MIF interacting with its receptor CD74 may increase adhesion molecule, increase cytokine and chemokine secretion, and favor immune cell recruitment and adherence. And the final comment will be on the external side of the vessel. We always like the endothelial cell, the smooth muscle cell, but we should never ignore what's around, and Kurt is working a lot on that. And the pericytes are certainly important for normal healing or abnormal proliferation. And in PH, and this has been published by Nicolas Ricard and Christophe Guignabert, it is quite clear that as compared to a normal pericyte in a normal vessel, there is an increased pericyte coverage, and this may be, at least in part, induced by abnormal production of FGF2 and interleukin-6 by dysfunctional endothelial cells. So once again, there are key players, there are usual suspects in PAH, endothelial cells, cytokines, interleukin-6, and often when you make a study and you want to show a mechanism, these players are involved. So my summary slide comes from the review article from Alice at Time to Change, because you had the paper by Marlene, so I put the one by Alice. And this is the link between immune dysregulation and pulmonary arterial remodeling. So there are, today we will hear a lot about it, a lot of innate response abnormalities in PH, a lot of adaptive response abnormalities, autoimmunity, at least a flavor, and certainly more. And these dysregulation will end up with abnormal function and abnormal remodeling of the small pulmonary vessels. And I would like to thank my group, Christophe Guignabert, who spent a year with Marlene, and Sylvia Cohen-Kaminsky, who is working with me in the Technion in Israel, Frédéric Perrault, who is currently in Quebec, and many others. Thank you very much.
That was really enjoyable, Marc. Since you've looked at immune phenomenon and idiopathic probably as much as anybody has, can you tell us how you think idiopathic PH is similar to, I'm just going to pick scleroderma PH, and how it's different with specific respect to the pathology of the lesion, but focusing on inflammation?
Yeah, no, it's a good question, and of course Paul is working a lot on that. So in scleroderma, you have quite prominent remodeling of the small pulmonary arteries, but you rarely have plexiform lesions. You have immune infiltration, but you have a lot of sclerotic remodeling. And I would say that when you see a classic heritable PAH patient under the microscope, it's more prominent in terms of proliferation. You have enormous plexiform lesions. You have hypertrophy of the systemic bronchial arteries. So there is a real pronounced pulmonary artery remodeling in idiopathic PH. And in scleroderma, it's more fibrotic, less plexiform, and certainly both are inflammatory.
Is there any difference in
Inflammation, I've not done a systematic study because it's difficult to have large amounts of pulmonary artery hypertension lungs from patients with scleroderma. With Peter, we did one small study. It was mostly scleroderma. And the very important finding was that pulmonary venous obstruction was more prominent than in idiopathic PH. But it's not inflammation. It was more a venous contribution to the abnormality. And honestly, I would like to do an international consortium to have 20 or 30 lungs from scleroderma PH, but it's difficult to make.
So I was very impressed by your data suggesting a pathogenic role for IL-6 in PAH, and I was wondering if people have looked at tocilizumab, IL-6 receptor blocker. You know, it's approved for rheumatoid arthritis and is very safe and well tolerated?
Yeah. No, it's a perfect question. It's exactly what we want to do. The Japanese have convinced, I think, a company to launch a small study. We have also discussed with Yannick Alanor, a scleroderma guy, to do a study with this compound. Obviously, we are not recruiting yet, but it's a clear... I mean, it took me a lot of time to decide, but now I think it's time to do it. Yeah.
Yeah.
Of course,
Well,
these patients are really, severe, and some tocilizumab-treated patients develop pneumonia, etc., and they may not resist to that. So we need a lot of safety data.
Hey, Mark, I want to continue on that point, actually. As a pulmonologist and as a clinician, this may be a naive question, but you've just now outlined in a beautiful talk the complexity of the immune and inflammatory milieu in forms of pulmonary hypertension. Is it naive to also think that one single therapy would be the key forward, or should we be thinking as a group of cocktails of therapies or regimens? I mean, that makes even more sense than the beautiful upfront vasodilator therapies that are now talked about. But here, there's pathogenic reason to really do that. It isn't simply just IL-6 per se in one individual. It may be one that's prominent in one versus the other. What are your thoughts about that?
Yeah, I fully agree with that. I think idiopathic by definition means we don't know what's happening. And we really have to subphenotype the patients. And I work a lot, with asthma specialists. And right now, I mean, when you have a severe refractory asthma, it's not at all the same thing if it is a eosinophilic type 2 asthmatic versus a non-eosinophilic non-type 2 asthmatic. And the new drugs targeting IL-5 are useless in non-eosinophilic and interesting in eosinophilic. Here, I enjoyed the conclusion of Marc because he said we have certainly to propose add-on therapies, but based on pathophysiological mechanisms. I think it's our job to subphenotype as well as possible the patients. I can tell you in idiopathic PAH, I'm always able to find an autoantibody circulating, but I don't know what it means. So it will not be enough to say something is circulating. We need something else. And right now, I'm entirely ready to analyze, for example, the breath of our patients. You mentioned that I have a strong collaboration with the Technion. We do measure the volatile organic compound in the breath of patients, and we are already able to distinguish patients with a BMPR2 mutation and no BMPR2 mutation, which is incredible. And so maybe in the future, we will have a BMPR2 screen systematically, and maybe one drug will be proposed versus another, and maybe we'll measure the blood and something else and see what's happening.
So, Marc, just one question. The place where you see all those immune cells, happen to locate to the same places that you saw an expansion of the vasa vasorum, which, probably is a derivative of the systemic circulation. And so have you thought much about, the role that bronchial circulation plays in continuing to provide the immune cell response that you, me, and quite a few others see on the outside of the vessel wall?
Yeah, no, it's a great question. We all think that there are two circulations. There are four circulations: artery, venous, lymphatic, and bronchial systemic. And really, we focus maybe too much on the affected, obstructed vessels, and we have to understand better the contribution of bronchial systemic circulation. Now we work a lot on that, and we try to understand if it's a source of cells which will contribute to remodeling of the vessels. The lymphatic tissues, the vessels are also very important. If there is a local immune reaction, the dendritic cells will have to migrate through the lymphatics to the local lymph node and back to provoke the local autoimmune response. So I agree, we have to study all the circulations. The bronchial circulation is important. I can tell you that in the BMPR2 mutation carriers, it's extremely large and hypertrophied, so it means something. But I'm just descriptive right now. I'm not able to say whether it's really acting in a pathophysiological way or just present. As you say, incidental. We don't know yet.
To extend on a couple of the prior questions, particularly the cocktail question and also the context question that came up in a couple of talks earlier. In the animal models that people are studying, is anybody looking at an antifibrotic agent together with an anti-immune agent? Because we know the context is important. We know there's a lot of intimal fibrosis. And at least in scleroderma now, the scleroderma interstitial lung disease trials are starting to try to look at these combinations.
Yeah. So, for example, in idiopathic lung fibrosis, you have pirfenidone, which is approved now for the treatment of these people. So we have also used antioxidant agents. We have studied antioxidant agents. In the animal models, it's working fine. But the gap between human studies and animal studies is very large. So right now, antifibrotic drugs, if you speak with people marketing bosentan, ambrisentan, etc., they will claim endothelin, and they're right. Endothelin is a very prominent pro-fibrotic molecule, and blocking endothelin is certainly it's meaningful for antifibrosis, but it's not a real antifibrotic agent. So
but the real question is, if you
combine.
If you combine
Yeah, but which one? Which one would you favor? Because it's, some of them, yeah, but some of them are VEGF blockers, and I wouldn't play with VEGF blockade in PAH. And pirfenidone, it's not working extremely well. So I'm not sure we have yet the magic bullet to test, but I'm ready to consider an antifibrotic treatment on top of what we have.
Thank you again for fantastic.